we move on to the next panel discussion, which will be on oligometastatic breast cancer, and for which I invite the moderator, Dr. Nanditha. I also take the opportunity till she takes the stage to invite the panelists, Dr. Nilesh Rokeshwar, Dr. Rona Joseph, Dr. Sachin Marda, Dr. Nishita Shetty, Dr. Nisha Hariharan, Dr. Pragna Sagar, and Dr. Sandhya Lakshmi.
Okay, thank you very much. At the outset, I'd like to thank the organizers for inviting me for this panel discussion. Feeling a bit out of place being a radiation oncologist and moderating a panel on metastatic breast. So I'll try not to go too much into the details of systemic therapy and expose my ignorance. So at the end of this panel discussion, we'll just try to focus on coming to some consensus about decision making in OMBC. So we'll start off with the case. This is a 40-year-old premenopausal lady who presented with a lump in her left breast. She had a mammogram which showed a 25 cross 21 millimeter tumor at 12 o'clock by RADS5. The axilla had a few small volume nodes which were reactive. Co-biopsy of the breast lump was IDC grade 2 and the axillary FNAC was reactive. IHC was an ER positive HER2 3+ tumor, and this is thus a clinically T2N0 cancer. So we'll start with one of the surgeons, Dr. Nisha maybe. What would you like to do at this point? Any further investigations, or would you like to suggest some treatment for this lady?
Since it's a stage T2 tumor and HER2 positive, we'd probably go for some staging investigations for her.
Like?
If it's a single investigation, we probably ask for a PET CT, or we may ask for a CT with a bone scan, any one of the two.
Okay. The other surgeon on the panel, Dr. Sachin, any difference of opinion? He's not here, sorry. Okay. So in our daily practice, are we doing PET scans as frequently for patients with just T2N0 tumors, or is something in the biology pointing you towards doing a PET CT scan?
Positive tumors are known to be aggressive tumors. So if we have something that's T2, looks like she might be going for neoadjuvant chemotherapy first, possibly, then I would like to have a staging investigation in place before we start any treatment.
Okay. So the ESMO guidelines are kind of on the fence. They ask you to do CT scans only in case of large tumors, node positive tumors. NCCN as well, I think, says stage them with more advanced imaging from 3A onwards. But you're right, in aggressive biology, things are a bit unpredictable. HER2 positive or TNBC, we would kind of edge towards doing PET CT scans. So we did go ahead and do a PET CT scan for this lady, and unfortunately for her, she was found to have 3 bone metastases, one in L2, left iliac bone, and the right ischium. And data as well shows that the yield of upstaging patients with stage 2A or 2B is fairly small, but is a significant number. Particularly in patients 40 or younger, there may be a better yield of doing a PET CT scan. So we'll start with one of the medical oncologists. Maybe you could give me your opinion now as to whether this lady would fit your criteria to call her as oligometastatic breast cancer.
Yeah, if you go according to the convention definition by the number of metastatic lesions, yes. But the second part of the definition, if it is, if all the lesions should be amenable to local therapy leading to a no evidence of disease status. So that, if I take that into consideration, then maybe no, because it's 3 different sites and I'm not sure if I'll be able to give a local treatment for all of them.
Okay, we'll go to our radiation oncologist, Dr. Pragna. Would you agree or disagree? Are you sure you can give local treatment to all these 3?
Can I see the image once more?
Sure.
So one is the vertebral iliac.
L2, left iliac bone, and right ischium.
Right. Technically feasible, but our threshold to give local therapy in breast as in practice is little high. So we would like we would consider local therapy only when we think that it helps to achieve the
No,
complete
the question I'm asking is it technically feasible or
It
not?
is technically feasible.
Okay, so this does qualify as oligometastatic breast cancer. Are there any sites that you would, Dr. Rona, that you would exclude from the oligometastatic conundrum, intracranial or anything of that sort?
So, apart from the IHC, in patients presenting with liver and lung metastasis, they do have a bad outcome if they treat with radical intent of treatment.
So if the same patient had visceral mets, then you would probably not treat her as oligometastatic.
We may consider, but I think not the single point, that is only the site or only the IHC, that is not a it should not be decided upon a single point.
Okay.
It should be based on total, patient's performance.
The whole picture.
Yeah, yes.
Okay. Dr. Neelish, anything to add?
I would differ here because there are few trials done by Fielder et al. And that was basically on lung metastasis. So lung metastasis, oligometastatic disease, which it is basically a retrospective data from different malignancies. And if it can be surgically resected, then it has good outcomes. It has shown good DFS benefit, of course.
Sure.
So this is essentially a very fluid diagnosis. Apart from the sites of disease, number of lesions, resectability, or whether they are targetable on radiation, I think what is also more important is the biology of the disease. So your presence or absence of hormone receptors or the HER2 receptor and the response to treatment. So I would look at all these criteria. There's no clear-cut definition. We're not even sure whether it's 3 lesions versus 5 lesions, whether it's less than 2 organ systems or more than that. So I think response to treatment and the biology of the disease is also an important characteristic.
Okay, so let's not label them upfront, but see how they do as we go along. Right, so the ESTRO and EORTC, they tried to make the definition a little simple for us, and they gave us only about 9 different definitions of oligometastatic breast cancer. So they talk about synchronous OMBC, oligorecurrence, oligoprogression, induced oligoprogression, etc. But the gist of this is similar to what Dr. Neelish said. It's basically something that can be treated with metastasis-directed therapy. The number of sites and the specific organs are not very fixed. However, those with meningeal, pleural involvement, or peritoneal involvement are, as a standard, excluded from the oligometastatic conundrum. And those with intracranial mets, you don't have to necessarily exclude them. So we'll go to the next person. I suppose you would start with systemic treatment. What would be your treatment of choice for this lady?
Yeah. So in any oligometastatic, I would first start with systemic therapy. So that would help us to understand the biology of the disease, and also we can allow the disease to declare itself oligometastatic, or whether it is going into a full-blown metastasis. So here in this case, since she is HER2 positive and young female, we'll go with anthracycline plus taxane regimen along with trastuzumab, or if finances is not an issue, then.
So you're going with more a neoadjuvant kind of a regimen rather than the Cleopatra?
Then reassess after 8 cycles, completion of all the neoadjuvant therapy.
Okay.
Assess again, and then go for definitive therapy of surgery.
Surgeon, would you differ in this? Would you like to offer her surgery upfront or anything?
The treatment plan, we'll start with systemic
Systemic
therapy
first.
first, followed by assessment.
Okay. So that's what we did. Although we used the Cleopatra regimen, docetaxel, Herceptin, and pertuzumab with zoledronic acid because of the bone disease. How long after you've started this regimen would you want to reassess this patient? Medical oncologist again.
So most of the trials, if you see, which have studied oligometastatic as such also, they complete all the therapy prior to taking into any kind of definitive therapy for the primary as well as the metastatic disease. So when you choose the regimen, if it's a 6 cycles, and we complete 6 cycles. If we are choosing anthracycline plus taxane, we complete 8 cycles.
Okay. So you'll finish the chemotherapy part of it and then reassess.
So I would consider this patient with a neoadjuvant intent.
Okay.
Give her 6 cycles of TCHP along with zoledronic acid and evaluate her at the end of 6 cycles.
Okay. So that's what we did. We did evaluate her at the end of 6 cycles. And she had complete metabolic resolution and sclerosis in all of the bone lesions, decrease in size and metabolic activity in the primary. There still is a small residual in the breast. So at this point, what would you do next, Dr. Nilesh? Are you going to continue with treatment, or Dr. Rona? Or would you refer it to somebody else?
The neoadjuvant chemotherapy will definitely go for surgery. And the adjuvant treatment will be based on the PCR, the pathology HPR report.
Okay. So the patient has now come to the surgeon. What kind of options would you discuss with this patient? Do you want to operate in the first place? And what kind of benefit or what endpoints are you trying to improve by offering surgery to this patient?
So surgery for oligometastatic breast cancer is extremely grave. We have unfortunately very limited evidence in this area. But for this particular patient, in a HER2 positive patient who's achieved near complete response with targeted therapy, we know that these women tend to do very well, and some of them go on to have a progression-free survival of about 90% for 5 years or so. So this could be a possible subset where we would go with curative intent, aggressive multimodality treatment. So we would offer surgery like we would offer with curative intent. As far as what surgery is concerned, both breast conservation and mastectomy have equal outcomes. So I would treat her like I would treat locally advanced breast cancer. If her response to treatment is good and she's keen on conservation, I would offer conservation.
Okay. So you would leave the option, discuss both the options with the patient. Fine. So this lady did have surgery and she had breast conservation. And like you said, the evidence is a bit sketchy in this setting. We have about 4 or 5 randomized trials actually on the role of surgery in metastatic breast cancer, but this is an unselected population. Not all of them were oligometastatic. And a meta-analysis of all of these trials showed that there wasn't any improvement in overall survival, but it possibly improved loco-regional progression-free survival. But this is not specifically OMBC, but a lot of them did include good risk patients. So this patient, like you said, was offered surgery, and this was her histopath, 2 centimeter residual with no lymph nodes involved. What now would be your take on systemic therapy?
So this patient has undergone curative surgery, correct?
Yes, she's had a BCS.
I would continue the maintenance trastuzumab and add a hormonal therapy for this patient.
Okay.
Excuse me, sorry. All the panelists agree that the surgery should have been done in this patient?
No. So I will just come to that.
So,
In oligometastatic breast cancer, specifically for breast cancer, there is no study like you mentioned which has shown an improvement in the OS. But there are several caveats in those analyses. Number one, they were older studies. Number two, they didn't have a homogeneous population. Number three, the drugs available today were not available at that point in time. So it's very difficult to say that this patient should have undergone surgery, but surgery is an option that can be considered for this patient. And there's no easy answer to say whether that would have really impacted her overall survival, especially in the presence of excellent anti-HER2 drugs that are available. So having said that, in a patient who's young, who's responded very well, I would definitely discuss that option out with this patient.
Okay. Since we are treating her sort of with the neoadjuvant kind of a setting here, given that there isn't PAT-CR, Dr. Nishita, would you want to change your systemic treatment at this point, or are you just going to continue with maintenance? Can one of you pass the mic?
Question. First of all, I would definitely not do a PET-CT and upstage this patient.
The reason I did a PET-CT was to check for internal mammary nodes.
So I feel it all started from there.
Yeah.
So if I would go from that line, yes, there's no PAT-CR, so I would tend to. But now if I've done a PET-CT, I really don't have evidence like if I'm treating it like a metastatic, if there is any role of changing the anti-HER2 therapy now, because, you have already labeled her as metastatic, so I'm not very sure, and especially when I know that there is no OS advantage for the surgery what we have done. But otherwise speaking, I would have definitely gone ahead and treated her with a curative intent with a change, if I would not have upstaged her in the beginning.
Okay. So whether to switch to TDM1 and use up a line of treatment or continue with dual MABs and reserve that for later, that I think is a debate that is difficult to answer. So Dr. Pragnya, so this lady's had curative surgery now, good response in the metastasis, residual in the tumor bed. She's had a BCS. She's now come to your clinic for opinion regarding radiotherapy. What are you going to offer her?
Yeah, I'm at a crossroads here actually. So I would offer SBRT to all the lesions, all 3 lesions, but we know that it may not actually add benefit even in the PFS based on the data, but most of the benefit of local therapy which we have seen is from the retrospective data. So that's probably related to the biology of the disease, and if we see the better response, a better PFS is seen in patients who had complete response. So in this patient who probably did not have complete response in the primary, I'd expect even we have a better systemic therapies available now. The radiological response is seen in the metastasis but might not actually have. So I would try to push for that CR and would offer SBRT.
So she does have complete response in the bone mets and only partial response in the breast. But you would still give SBRT to all of the bone lesions, and what about the breast? She's had a BCS.
Yeah.
There is some evidence that doing the surgery increases PFS somewhere. There's no evidence that metastasis directed therapy in a complete CR would actually make a difference. And
Yes,
I don't see, so I'm not sure how many of the panelists would agree to give, okay, you're giving BCS and so you want to give breast RT, I don't know if that's fine, but metastasis directed therapy, panel can take that call.
Any of the medical oncologists have any take on metastasis?
From the point of chasing particular lesions and giving radiation, I don't think I would do that in this setting. Like I said, it's all dependent on the availability of systemic therapy options that you have. So your HER2-directed therapy, your hormone therapy is probably going to do an as good job.
Okay.
So,
So I would say there is...
What about the breast for radiation?
Yeah, so I think Dr. Pragnya was
Sir,
on the fence about that.
Since I am giving SBRT, I would like to reduce the local recurrence rates even in the breast. I'd go with whole breast RT.
With what regimen?
With 40 and 15.
Okay. Not fast forward? She's metastatic. Why would you want to give
Yeah,
her
fast
green
forward
fractions?
also is.
Okay. So we did fast forward for this lady for the breast, and we did metastasis directed therapy because at the time we thought it was a good idea because of this trial, the Sabre Comet, which was published in 2019. This was a mixed bag which had breast, colorectal, prostate, and most of these patients were oligo-recurrent. So they had a 2 or 3 year of DFS and then relapsed. And this showed improvement in both overall survival and PFS. Dr. Shalaka, you have something to say?
So just the previous meta-analysis, 2 comments I have.
Yep.
The previous meta-analysis of metastatic breast cancer that you showed, which
The
also...
surgery you meant.
Yes.
Yeah.
When surgery did not show benefit. The only study that was positive in that was the Turkish trial.
Yeah.
So the ECOG-ACRIN and the TMH study also was negative, right? But we had a predominantly 80% of them were polymetastatic. Only 20 to 25% were really oligometastatic.
And most of them didn't get anti-HER2 as well.
Yeah, the caveats of the study, yes, they're very well known. And we have better anti-HER2 therapy. Hence, we should treat them with a curative intent with surgery because we have better anti-HER2 treatment is what I feel.
Sure.
But like everybody said, there is no randomized evidence. So we can just keep discussing it in every meeting and we'll have no answers at the end, unfortunately. The second point is we should treat the metastatic sites because the entire idea of even the earlier M1 study that we started back in 2008 and published in 2015 was the fact that there were animal experiments which showed that when you treated the primary, the metastatic sites grew. Yep. So that premise is believed in treatment of oligometastatic breast cancer. So if you see the ABC guidelines also say that you should treat the metastatic site. So
if you're doing the surgery, then treat the mets as well.
Because the hypothesis, again, it's a hypothesis and we don't have randomized evidence. I accept that. But having said that, it is coming from the hypothesis that if you treat the primary alone, the metastatic sites may regrow in future. Hence, I do believe in your SBRT being done in this situation. The other thing was that we will need a multi-center India-based randomized control trial if the West is not doing it. So we should end that with the discussion that we should have a trial rather than beating around the bush each time. But
So one point that I had was that actually we cannot be confused in our approach when we are treating a patient and doing some things and not doing some things. If you are treating a patient
Either
as
go all out and do
yes,
everything.
absolutely. So if you are treating as a oligometastatic disease with the intent of cure, go all out and do everything that you would do for the patient, including changing over to TDM1 in this case, like if there is a no path CR.
Okay, fine, point taken. However, just a note about the metastasis-directed therapy. This was a disappointing trial for all radiation oncologists. The NRG-BR002 presented at ASCO, the full paper is not yet out. Well-designed OMBC trial where they looked at metastasis-directed therapy versus just standard systemic therapy. Unfortunately, it was a negative trial, did not reach its primary endpoint of improvement in PFS, and so the trial was closed to accrual. The majority of this, the trial population were in fact the good risk patients with ER positive, HER2 negative with bone-only disease. So, I mean, theoretically, it makes sense that you treat the primary, you treat the mets as well, but unfortunately a randomized trial did not actually show that was what we were going to achieve. However, the full paper is not yet out, and these were ER positive patients mostly, so maybe not generalize it to all other patients as well. So coming back to the medical oncologists, so this, having now talked about the BR002 study, do you think the HER2 positive or the TNBCs should be treated differently? And are you convinced that we now omit metastasis-directed therapy in ER positive cohort with a randomized trial telling us that we shouldn't do it?
Sorry, what was your question?
Are you going to treat HER2 positive patients? So if you look at this trial, a randomized trial saying metastasis-directed therapy has no benefit in either PFS or OS, this was a cohort with mainly ER positive patients, which we think are the actual good risk patients. So since it didn't have HER2 positive or TNBC patients, should we just start treating them differently, or would you now generalize this trial and say that you won't do metastasis-directed treatment? I think you didn't want to give SBRT in the first place anyway.
But having said that, you can't generalize, that's for sure. And triple negative breast cancer is an area where I don't think the concept of oligometastatic really comes about. We understand that not all triple negatives are aggressive tumors. There's a 20% of patients who have slower tumors who we can't identify. So having said that, if there's a patient who's got a triple negative breast cancer, metastatic, in the definition of an oligomets, who's got a good response to therapy, I would still not consider localized therapy for a TNBC.
Okay.
On the contrary, in HER2 positive as well as in ERPR positive, I would consider something local.
Okay. Dr. Rona, do you think this, like we chase path CR in the neoadjuvant setting, are we chasing clinical NED in the metastatic setting? Should that be the aim of our treatment for oligometastatic breast cancer?
Both are important, both clinical response and the pathological complete response. And regarding the previous question, regarding the HER2 positive, because we have got a lot of anti-HER2 options now. So if you are deciding, first thing is to decide whether to treat the patient with a radical indent or a palliative indent. And if you are planning to continue with the radical indent, then of course it is better to treat with a radical treatment mode, that is changing, escalating or de-escalating based on response and giving radiotherapy or metastatic-directed therapy also.
Okay, sure. So there are studies to show that achieving clinical NED in de novo HER2 positive breast cancers does improve survival. 5-year overall survival in patients who achieved a clinical NED was 98% and 10-year OS as well 98%, whereas those who did not achieve clinical NED and had residual disease had a much more inferior survival. So I think for the HER2 positive patients, it does make sense to chase clinical NED.
But these are highly selected populations because this is a retrospective analysis.
Sure.
So it has those limitations.
Yeah. So we talked about this, whether to switch to TDM1 or continue with dual MABs. I think the forum is kind of divided about that. What about duration of systemic therapy? Dr. Nishita, would you continue kind of until progression, or are you going to treat like you would a neoadjuvant and stop at 12 months?
So in oligometastatic, I think I would really take a call after a year because, even if it is not de novo oligometastatic, if you say the persistent oligometastatic status also, there is a good, there are studies which have shown that there is an inclination to a better survival if the DFS is more than 2 years. So in case if the patient continues to be in CR status maybe after a year, I would consider to stop it.
So at 12 months, you would take that call. So at 12
Because
months, she's had a PET scan, no disease anywhere. Are you going to stop?
If I have treated the primary as well as the metastatic site, I would stop it.
Okay. Any difference of opinion on this?
If you are treating with the radical intent, then give the radical treatment. That is, give 1 year anti-HER2 treatment.
1 year.
Yeah, that
Dr.
is.
Sandhya?
Yeah. So here there is no particular answer or perfect answer. But I would say when we are treating oligometastatic disease, there's more data from lung if you see. The whole purpose is to give good quality also. So we usually tend to follow the lines of locally advanced when it comes to maintenance. We don't want to give maintenance for a prolonged period of time and do so many therapies, and finally patient is taking treatment like a metastatic disease without any reduction in the maintenance part.
So if you choose to treat radically, then you would
You
stop
should,
at 12 months.
yeah.
Dr. Nilesh, any difference?
So I think Ashish put it perfectly. Intent of treatment you decide upfront and follow that closely, because otherwise you can never come to a clinical decision. Otherwise, ye dil mange more. Sometimes you want to go this way, sometimes that way. It's very difficult. And yes, of course, you will keep this patient under more closer observation, and this will be with the discussion of the patient. But I will, if I do decide that this is going to be a curative intent, until the end of curative therapy, the patient remains in remission, I would stop treatment.
Okay. So there is some retrospective case series where patients have, so in most of the trials, patients have continued standard of care systemic therapy, although we agree that we should possibly stop if we decide to treat them with a curative intent. And HER2 positive patients, those who've even discontinued her anti-HER2 therapy after achieving clinical NED have done well. So that may be the way to go. So this lady continued 12 months of treatment and had clinical NED, and then unfortunately 6 months later came back with headache, vomiting and giddiness, and had an MRI brain with contrast, and that's what it showed. There's a solitary met in the right cerebellum. PET scan was still NED. So this patient has now come back to the medical oncologist. What would you now suggest that this lady have?
So this is the only site of disease.
Only site of disease.
I would consider a surgical excision for this disease. Okay. And from 2 points of view. One is I have a histopathology again, which confirms or changes the hormone status of this patient and the HER2 positive status. And the treatment itself may be potentially curative for her. So I would consider a surgical excision if that's the only site of disease.
Okay. Dr. Pragya, any difference of opinion? Would you offer surgery or would you treat her with radiotherapy?
No, I'd go ahead with radiotherapy upfront. The most likely that she would still be of course we want to know the change in status, but here after surgery I have to add SBRT again, which will increase my volume, and we do not exactly know how much benefit.
What kind of radiotherapy would you offer?
I'll go with SRS. Looks like a small disease, single fraction if it is. Can I know the?
It's about 3.5 centimeters. There's perilesional edema. There's
3.5 centimeters.
It's a
Sorry,
single-site
it looks
lesion
very
in the
small to me
cerebellum.
from here.
Why not surgery?
Yeah, so I would agree. This lady was fairly symptomatic. There's significant perilesional edema, single site of disease. She probably has a good long-term outcome. These would be the candidates that you would choose to offer surgery. And that was what we did, and we offered her cavity SRS once the surgery was done. So now that she's had a relapse, she's come back to the medical oncologist, she's had surgery, she's had radiotherapy. What are you going to do now? Are you just going to continue on endocrine treatment or switch or go back to Herceptin?
So yes, assuming she will be ER/PR positive and her trastuzumab and HER2 positive also, I would consider her to directed therapy. Now here the question is this going to be in a semi-adjuvant kind of a situation or a palliative situation? I would consider this as a situation where I'll continue the treatment for a longer period of time and not stop at 1 year.
So she stopped at 1 year and there's a 6 months gap.
So
and this
the
is
second
also
time around I won't do that.
So are you going to go back to Herceptin now, or are you going to go to second line treatment?
It's a 6 months duration, so I would probably consider a second TDM1 would be an option there.
Okay. So the guidelines as well say that you treat these patients radically, surgery, SBRT, and it doesn't really take a call as to whether you switch treatment or continue with the current treatment. So this lady surprisingly had ER positive disease, but her HER2 is now turned negative. She's HER2 2+ and is FISH negative. So what are you going to do now? Are you going to start her on a CDK4/6 inhibitor, or?
TDX.
But did any of the TDXT trials include this population who have turned HER2 low after treatment? Sorry? Any difference of opinion? Everyone would start TDXT?
No, so this is a
And keep
situation
her on
where
it
it's a
lifelong?
resected tumor,
Yes. Resected, radiated, no other disease.
I would probably consider a second line hormone therapy. Maybe even a single agent hormone therapy, not necessarily, because this is like an adjuvant setting actually, if you look
So
at it.
I would say this is a patient who underwent all the therapy and she had a oligo recurrence, which has been excised. So there is no need for a change in systemic therapy because that was the single site lesion which was excised.
Yeah.
And she is hormone positive from the beginning. So I would want to just continue hormonal therapy and not introduce any.
We would like you to finish early, ma'am, because we're already running late.
I thought I had 30 minutes. Okay.
No,
Anyway,
it's
in the
over.
interest of time, we will just skip to conclusions. Just a couple of other instances, oligo recurrence, like this instance. We would agree that most patients benefit from aggressive treatment, and oligo progression, unfortunately, there is another randomized trial, the CURB trial, which says adding metastasis-directed therapy in breast cancer does not add to benefit either PFS or OS in oligoprogression. So just some final statements. OMBC, fact or myth? Let's start from Dr. Nishita. One word answers, please. It is a fact, okay. De novo OMBC surgery to be offered, yes or no, Dr. Nisha?
In very, very select patients.
Okay, so select patients with the benefit of possibly improving local regional PFS. Metastasis-directed treatment in ER positive OMBC, Dr. Pragya?
I'll still stand with yes.
Okay. Unfortunately, I disagree because BR002 says there's no benefit of it. HER2 positive and TNBC?
HER2 positive, yes, and TNBC not in all cases.
Okay. And oligo recurrence, I think we agree that you could possibly offer it because Saber Comet had mostly this population, and oligo progression maybe not because of the CURB data. Thank you very much for a patient listening.
Thank you, Dr. Nanditha, and especially for summarizing and giving the take-home messages at the end of the panel discussion. And thank you all the panelists.